Hello and welcome to our bi-monthly CMF podcast. I'm Professor George Bakris, Professor of Medicine and Director of the American Heart Association's Comprehensive Hypertension Center at the University of Chicago. The CMF is a free educational resource for clinicians, and this podcast aims to update you on some of the latest publications in the field of cardiometabolic diseases and the implications for clinical practice. Today, I'm joined by Professor Darren McGuire, a professor in the Department of Medicine and a professor of internal medicine at the University of Texas Southwestern Medical Center. Darren?
Hey, George. Good to see you. Looking forward to this chat about these three papers that have been selected from the literature search over the last couple of months by the CMF staff. And we'll be diving into some cardiometabolic papers, including analyses of empagliflozin, tirzepatide, and orforglipron. So, George, if you want to take us through the first paper, the sub-analysis from the EMPULSE trial based on MRA use.
Well, thanks, Darren. So let's take a look at this first paper by Ferreira. Sorry if I didn't pronounce that correctly. Looking at mineralocorticoid receptor antagonist use and the effects of empagliflozin specifically on clinical outcomes in patients admitted for acute heart failure. And this is the findings from the EMPULSE trial. So if you look at this, it's a post hoc analysis of this randomized double-blind placebo-controlled trial. And it was looking at efficacy and safety of treatment of empagliflozin at the 10 milligram dose, so not the high dose, versus placebo for 90 days. And this was in 530 patients with acute heart failure between 1 and 5 days after heart failure hospitalizations. Now, 52% of the people were on an MRA, and patients with a primary diagnosis of acute de novo or decompensated chronic heart failure, regardless of a left ventricular ejection fraction, were included in the study. And these people did have kidney disease because the GFR, you could get into the study with a GFR of greater than 20. The primary endpoints were all-cause death, heart failure events, and a greater than or equal to 5-point difference in the KCCQ total symptom score after 90 days assessing. This was assessed by a win ratio method. And then there was a secondary endpoint of first heart failure hospitalizations or CV death. So if we look at this in terms of the background and the methodology, I've already told you about the important findings of the important makeup of the study. And now the question is, what were the outcomes? And many of you may think that if you were on an MRA, you did better. However, the primary outcome did show a benefit of empagliflozin, irrespective of baseline MRA use. So when you look at the win ratio, it was 1.46 for MRA users. And when you look at it for non-MRA users, it was 1.27. Interestingly, the investigators reported very few or infrequent severe hyperkalemia events with the use of MRAs, for those of you that were worried about it. So I think these are important findings because we all know that SGLT2s clearly have a role in reducing risk for heart failure hospitalizations and improving outcomes in those patients. But now we have a situation in an acute setting for heart failure and looking at MRA use and frankly, some interesting findings. You know, Darren, you're the cardiologist. So what do you think about this?
Yeah, I was glad that we picked this study. It's a small study. It's a post hoc analysis, and it's non-randomized exposure to MRAs. But it kind of tells us what we expected to find. One is it looks to be safe to initiate SGLT2 inhibitors in the hospital. That's what the EMPULSE trial overall taught us, and at least in our practice, we're really incorporating that, getting people on SGLT2 inhibitors during their hospitalization, at least at the time of discharge. And a couple of interesting observations here. One is, despite the presence of MRA use, there was no higher rate of hyperkalemia. And we've seen this across the SGLT2 inhibitor trials. There's a slight decrease in potassium, not very much, not clinically relevant, but it seems like SGLT2 inhibitors may prevent MRA-induced hyperkalemia.
Well,
So,
Darren, let me just interrupt you and
yep,
because I
sure.
want to really emphasize this point, and I'm glad you brought it up, because in fact, when we looked at this specifically, and this was published in JASN in the finerenone studies, people, and these are people with a GFR in the 30s
Right.
that were on an SGLT2 had a significantly lower risk of hyperkalemia with finerenone than even people on diuretics. So this is a very important observation.
Yeah, and then a couple other nuances of this trial is we're seeing this more and more in the heart failure field, especially this use of the win ratio analysis. This is a series of head-to-head analyses pitting one person versus another thousands of times. First, analyzing death, so it's a weighted analysis. The most important analysis is done first, all-cause mortality, and then it's followed by total heart failure hospitalizations. Then it's followed by time to first heart failure hospitalization. And finally, at the end, everyone contributes to the outcome by having a KCCQ total symptom score. And so this is a way to allow every single participant in the trial to contribute to the analysis. It does dilute the hard outcomes with some softer patient-reported outcomes and scores, but at the end of the day, these are all legitimate measures of how patients experience heart failure. So it's not to belittle the importance of this study. And at the end of the day, and again, interpreting the win ratio, it's basically the inverse. It's not exactly the inverse, but when we see point estimates greater than 1, that's a favorable thing, unlike what we're used to seeing hazard ratios and odds ratios where point estimates less than 1 are favorable. So this just shows us that somewhere between 27 and 46% of the time, persons on empagliflozin win over persons on placebo, independent of background MRA use. So
So
again, it's post hoc. And then the last thing I'll say is, again, it's not a randomized exposure. And these investigators didn't really do much to adjust for the differences in exposure of MRA versus not. We would typically like to see a propensity score or propensity adjustment for the likelihood to be prescribed the MRA, adjusting the outcomes. But I'm actually not even sure if you can do that in a win ratio analysis. I'm not familiar enough with the methodology, but at the end of the day, it tells us what we'd like to see. We're using these commonly inpatient, commonly with MRAs, and it looks like it's safe and similarly beneficial.
you made a very important point, and this was my bad because I didn't really define it, but clarifying the win ratios for the listeners, I think, is really an important thing. So bottom line, and you summarize this very nicely in terms of conclusions, that empagliflozin is already in a lot of drinking water, and now we're putting it in even more drinking water in people with heart failure and having an acute heart failure attack. So it's very useful, not just in a chronic setting, but in the acute setting. So Darren, let's move on to the next paper.
All right, the next 2 papers we're going to talk about have to do with the incretin modulation and pharmacotherapy for obesity. This first paper correlates a trials program, the SURPASS trials program, a combination of 5 different randomized trials evaluating tirzepatide, the dual GLP-1 receptor agonist, GIP receptor agonist. So 2 different incretin parallel pathways are being agonized with tirzepatide. Many of you are familiar with this drug and its effect on weight loss that's been widely publicized, and tirzepatide is presently under evaluation at the FDA for an indication for weight loss. But here we're going to talk about the hemoglobin A1C effects across this SURPASS trials program. This is pooled analysis evaluating 3 different doses, 5, 10, and 15 milligrams once weekly injectable of tirzepatide versus placebo across all of these studies with different background therapies, either using tirzepatide as monotherapy, adding these therapies to metformin or insulin glargine or insulin degludec, or the combination of glargine and metformin. And what was shown across every one of these trials is tirzepatide had a dose-dependent reduction in hemoglobin A1C. These trials have all been reported, and tirzepatide is approved for use to lower hemoglobin A1C in persons with type 2 diabetes. But importantly here in this trial, they analyzed across the pooled analysis the association or correlation between the amount of A1C reduction with the amount of weight reduced. And there was a modest correlation, as you can see on these scatter plots. It looks more like a shotgun plot than a linear association. So these are modest associations, but they are statistically significant, ranging across the trials from 0.14 to 0.32. So a correlation coefficient somewhere around 0.25 on average. So there is some dependency of the A1C with weight loss, but there's also clearly an independent A1C effect, independent of weight loss achieved. And again, like all incretin modulators, this drug did have a dose-dependent GI intolerance. Somewhere around 10% of persons across this trials program had to stop the study drug because of GI intolerance, but that means 90% tolerated the drug, a very useful number. And as you can see, very effective at lowering hemoglobin A1C, ranging from 1.3 to 2.6 absolute A1C reduction. And the 2.6 was achieved in the top dose of tirzepatide on top of basal insulin. And so this is a very potent GLP-1, GIP, very potent at lowering hemoglobin A1C on top of conventional therapies, and importantly, very little incremental risk for hypoglycemia. So you lose weight, you have less risk for hypoglycemia, a lot of favorable effects. Blood pressure goes down independent of weight loss, as does favorable effects on lipid profiles. So again, another win for tirzepatide. These drugs are really taking over the clinical landscape, and we're using them routinely for hemoglobin A1C treatment, but also now getting towards using them routinely for weight reduction, with the caveat, as everyone knows, these are very expensive medications. So we're going to have to figure out, George, how we're going to get these things to the patient.
Well, this is an important point, and before we discuss that, I want to make a point for the clinicians, because I think a lot of clinicians think, well, this is a great weight loss drug, you're going to lose weight, so everything's going to get fixed. And clearly here we have a dissociation, so it's doing other things, but there's an intolerance to these drugs that you pointed out, Darren. And it's not just this, it's the class. And one of the reasons for that is these drugs work on the gut to slow gastric emptying, they slow things. So a lot of the nausea that patients will exhibit, and they will exhibit it, is related to the amount of food they're eating. So you're better, rather than gorging out like a lot of people do, really setting up meals. So you're eating 4, 5, 6 times a day, but the meal size is the size of your palm. And if you do that, you're going to be much less likely to have significant nausea. You may have a little bit, but it's not going to be significant. And then that's just a little point that I'm putting out there that all of my diabetologists have told me, and I've observed it myself when I dose it and instruct the patients in that regard. So I think that's a big deal. Now, as far as the payment goes, and we could be here all day with this, but I think what people don't look at, what business people in the insurance industry don't look at, is the potential cost savings on hospitalizations for a myriad of morbidities associated with obesity. And bottom line is that the system has to change in terms of how it evaluates things economically, because there's no one is going to argue there's cost savings if you use these things long term. But the point is, the insurance companies don't fund anything more than the year. So you're going to lose no matter how you do the math. So I don't have a solution for that except to change it. But if you've got something, happy to listen to it.
Yeah, you're exactly right. You know, I'm fortunate. I work in the Parkland Health System, the county health system in Dallas, and we are privileged to have a P&T committee that thinks way outside of the box, just as you suggest. And so we've done the mathematics, and it actually becomes cost dominant in a closed healthcare system like Parkland Health System. So we have unrestricted access to liraglutide and semaglutide, not for weight loss specifically, but we're certainly using them in patients with type 2 diabetes and appreciating the weight loss that we're achieving in this high-risk patient population. And just a couple of additional points. I completely agree with small meals helps with the nausea. And for the cardiologists out there who are just maybe considering the pre-anticipation phase, if you will, of prescribing these in your usual practice, start low and go slow in the titration. Wait until all the nausea and GI side effects are gone before going to the next dose. And if you do that, it may take 2 or 4 or 6 weeks, but it will go away. And if you titrate only after the GI side effects are gone, patients will tolerate this much better. One additional
Absolutely.
point, this fear of injection. These needles are 35 gauge. You cannot feel them go into the skin. It's not that they don't hurt much. You can't feel them. So get over the fear of the needle. It's really not relevant with these injection pins that are being used. And the last point I'll make is, at least 20 years ago, the World Health Organization began discouraging the use of alcohol wiping before you inject a small volume. So you don't even have to cleanse the skin unless it's visibly soiled. Just bare the skin and inject. It takes 15 seconds. I would take once a week injection of these drugs over a tablet every day of the week. So I think as cardiologists we have, and I'll finish with this. I had the privilege of being on the European Society of Cardiology Diabetes Guidelines Writing Committee, and we unequivocally endorse both SGLT2 inhibitors and GLP-1 receptor agonists as level 1 indications, not either or. Use them both in patients with diabetes who have atherosclerotic cardiovascular disease or at high risk for it.
Well, the bad news for the audience is you and I agree 10,000% on this, Darren. So we need to move on. Um,
Yep,
so
your turn, George.
yeah, I got it. I got it. The final publication that we're going to be discussing is by Wharton et al. And they evaluated the efficacy and safety of Orforglipron. I say that 4 times in a row.
Easy for all of us to say.
That's right. In adults with obesity or with overweight, plus at least one weight-related coexisting condition, and without, this is important, without type 2 diabetes. So this is a big deal. So the baseline characteristics of this study, people were in their mid-50s, 54 was the mean age. The participants were mostly female and they were white, 59% female, 91% white. And the mean body weight was 108, almost 109 kilos, with a BMI, call it 38. So on the large size. And the treatment groups appeared to be well balanced for demographics and disease-related characteristics. All right, so the other thing is that was pointed out, and I failed to mention this, is that these people also had albuminuria. So they clearly had evidence of kidney disease, and as we now know, even small levels of albuminuria are a risk marker for heart failure. So I think we have to, pay attention to that. The drug was given once daily. It's an oral non-peptide GLP-1 receptor agonist. And the bottom line is it's in development. So this is a phase 2 double-blind trial. And it evaluated the drug in people, as we said, with type 2 diabetes, obesity, etc. 272, this is a phase 2 now, so it's not an outcome trial. 272 participants were randomized to orforglipron, say that 3 times, 12, 24, 36, or 45 milligrams. So 4 doses or placebo. And it was 36 weeks. At week 26, the primary endpoint was the mean change from baseline in body weight. So what was the change in body weight? 8.6 to 12.6% across the drug dosing range, 2% with placebo. So clearly the drug caused weight loss, which is what you wanted, and it did it in a dose-dependent fashion. Weight reduction of greater than or equal to 10% by week 36 occurred in 46 to 75% across the dosing range, only 9% with placebo. And the most common adverse event reported were GI effects, as you'd expect, but they were transient and they were mild. And there was some discontinuation related to GI adverse events, and it was about 10 to 17%. So I think the bottom line is this drug does cause weight reduction. The GI side effects are predictable because they're in the family of the GLP-1 RAs, and that is what you would expect. And as we just finished discussing in the previous paper, we gave you the recipe for how to minimize those and ensure adherence with proper dosing in these patients. So, Darren, what are your thoughts?
Yeah, I think this is really encouraging. This is now the second oral GLP-1 receptor agonist formulation. We have semaglutide oral on the market for the treatment of type 2 diabetes. presently undergoing a cardiovascular outcomes trial. So that's trade name is Rybelsus, or oral semaglutide. That's a once daily tablet like this one. The interesting thing here is this is a non-peptide, so it can get by the gastric acidity, and so the absorption here is going to be much more reliable than the tablet of semaglutide, where it only has 0.8% bioavailability. So you excrete out in the feces 98.2% of the drug.
And Darren, let me interrupt you. Let me interrupt you because I think the audience needs to understand that this, if you're going to give Rybelsus, you need to give the patient very specific instructions on how to take it, because if they don't follow that, and a case in point, I've had in the last month 3 different patients coming in, and they're telling me the drug's worthless. And they said it seemed to work in the beginning, now it doesn't work. And I asked them how they take it, and clearly they weren't taking it correctly. And then I asked them if the physician explained it, and they said, well, yeah, they said something, but it was too complex, so we didn't follow it. Well, that's why you didn't get any results. And it's a pretty expensive pill to throw down the toilet. So I think I just wanted to put that out there for the listeners.
Yeah, and to
Sorry.
be specific, the advice is to take this on an empty stomach first upon wakening, and don't eat or drink anything except for 6 ounces of water with the tablet for at least 30 minutes. This tablet, the semaglutide tablet, actually sticks to the gastric mucosa, and the point of contact is the only place that gets absorbed from the tablet. So you have to have it stuck on the gastric wall and not have food and water interrupting that. But getting back to this study with Orforglipron, and I'll just, I shared with you before we started, so the name of this drug comes from a condensation of the oral formulary of GLP, and so it's Orforglipron, which is very creative. It'll be interesting to see the trade name if it comes to market. But I think what's really remarkable here is we're getting about 50% of patients on this medication achieving 10% or greater weight loss. You know, the regulatory standard for weight reduction therapies in the US has been at least on average 5% weight reduction, and that's been the case for 20 or 30 years. So now we're having a series of drugs that all have in excess on average of 10% weight loss, some as much as 20% weight loss. So I think it's time to change the regulatory standard. We need to expect more from these therapies, and it looks like we're going to have several to choose from. So this is really encouraging. It's early data. It's phase 2. There's always possibilities of things coming up in the larger scale exposure that we don't anticipate. But so far, the side effect profile looks very clean. You're getting weight loss. In addition to this, you're going to have hemoglobin A1C reduction. This was not a patient population with diabetes, but it's likely we're going to see data from this study program and others where we're actually reducing the incidence of type 2 diabetes by treating with a pre-diabetic condition with these drugs, but by virtue of the glucose effects and also the weight reduction that we're seeing. So I think these are going to be taking the world by storm for the next decade as we learn to use them in broader and broader populations.
Very good. So we hope you've enjoyed the discussion in this podcast and find it useful and informative for your clinical practice. For slide summaries on further publications, head over to CMF at Cardiometabolic.com. All resources are free to download for your own updates, teaching, journal clubs, and more. To stay up to date with new updates, join our mailing list and follow us on social media to find out when more slides, literature highlights, and podcasts go live.
All right, George, I'll close it down. As always, it's a pleasure spending time with you. It's been nice reviewing these 3 papers. And for those of you who are interested, go to the CMF website where you can see archived podcasts from previous public or presentations. And as always, we wish you the best in your clinical practice. Thank you.